My name is Jake Nichols, and I am currently Director of Clinical Affairs at a division of the UMass Medical School known as Commonwealth Medicine. Our department in particular, Clinical Pharmacy Services, provides a wide variety of different services to many different managed care clients, including Mass Health, Neighborhood Health Plan, Vermont Medicaid, and Alabama Medicaid. The focus of our presentation today will be the use of medications for the treatment of symptoms associated with COPD. And in particular, we'll be focusing on the benefits of these medications in reducing morbidity, keeping patients out of the hospital as well as the emergency room, as well as mortality, reducing overall death associated with the disease. The goals and objectives for the presentation will be as follows. Number 1, interpret current guidelines and measures for effective management of chronic obstructive pulmonary disease, or COPD. We'll be focusing specifically on the Global Obstructive Lung Disease, or GOLD guidelines, initially created in 2001 and updated last November 2006. Number 2, list drug therapies that have been shown to decrease exacerbations, hospitalizations, and overall mortality in patients with COPD. The majority of costs associated with COPD are due to emergency room visits as well as hospitalizations. And last but not least, given a patient case, make recommendations for improvements in drug therapy that are likely to improve overall clinical outcomes, specifically in the area of drug therapy. We will begin our presentation with a patient case, which we will follow throughout the duration of the presentation itself. MM is a 72-year-old female with a history of COPD, hypertension, osteoarthritis, depression, insomnia, and gastroesophageal reflux disease. For her osteoarthritis, she's currently taking celecoxib and hydrocodone acetaminophen on an as-needed basis. For her depression, she takes sertraline 100 milligrams daily. Her insomnia is being treated with a combination of trazodone and zolpidem. Her GERD is being treated with pantoprazole, and her COPD regimen currently consists of salmeterol 1 inhalation twice daily, tiotropium 1 inhalation once daily, as well as albuterol on an as-needed basis, 1 to 2 inhalations every 4 to 6 hours as needed. MM currently smokes 2 packs per day and tells us outright that she has absolutely no interest in quitting. She quit smoking crack cocaine about 10 years ago, does not currently use any alcohol or any other recreational drugs. She is currently having issues with trouble breathing in general, which we refer to as dyspnea, as well as insomnia. She reports that she wakes up on average 3 to 4 times per night coughing uncontrollably and as a result has difficulty falling back asleep. In addition, she's visited the emergency room 5 times over the past 12 months, and she was hospitalized 4 out of 5 of those times. Given the information provided to you about MM, which of the following would be appropriate to assess? Number 1, control of GERD symptoms. Number 2, appropriate inhaler technique. Number 3, understanding of the term rescue inhaler. And number 4, all of the above. Of course, the correct answer would be number 4, all of the above. GERD symptoms have recently become a topic of great discussion in COPD, and we now know that control of GERD is essential in helping to control overall symptoms of COPD as well. As a pharmacist, probably our prime role is to evaluate inhaler technique and ensure that patients know how to not only appropriately use their inhalers, but also understand which inhaler is for maintenance treatment as well as which is for rescue use. Which of the following medications may not be suitable or ideal for MM? Nadolol, being a non-selective beta blocker, has the potential to antagonize the effects of inhaled beta agonists. And in this case, albuterol and salmeterol may not be reaching their full desired effects. Zolpidem, a benzodiazepine agonist, is less likely than traditional benzodiazepines to have direct respiratory depressant effects, and as a result, many clinicians have grown comfortable using these agents in patients with respiratory disorders. Finally, narcotics have a long-standing and well-known respiratory depressant effect. Unfortunately, the likelihood of getting this patient off of this agent, given the fact that she's been on it for over 20 years, is very, very slim. The American Lung Association defines COPD as a term referring to 2 lung diseases, chronic bronchitis and emphysema, that are characterized by obstruction to airflow that interferes with normal breathing. Both of these conditions frequently coexist, hence physicians prefer the term COPD. It does not include other obstructive lung diseases such as asthma. The key piece to keep in mind here is that COPD tends to combine attributes of both chronic bronchitis and emphysema. Emphysema is destruction of lung tissue by enzymes that run rampant within the lungs, breaking down protein. We think of chronic bronchitis as simply a chronic cough with excessive mucus production. And obviously, if you combine both elements, it tends to lead to the symptoms of COPD, namely exercise intolerance as well as trouble breathing. COPD is currently the fourth leading cause of death in the United States, contributing to over 120,000 deaths annually. There are 11.4 million United States adults who are estimated to have COPD, although there are close to 24 million adults who have evidence of impaired lung function, suggesting inadequate screening in this country for the disease. Over 638,000 annual COPD hospitalizations, and over 65% of those hospitalizations are in patients aged 65 years and older. About $21 billion are attributed to direct costs associated with COPD, $7.4 billion in indirect morbidity, and another close to $9 billion in indirect mortality. COPD is unquestionably a very large contributor to the billions, if not trillions of dollars spent on healthcare annually in the United States. The rule of 50s helps to highlight how debilitating and serious of a condition COPD really is. As we've alluded to previously, 50% of patients with COPD are undiagnosed. In most cases, COPD is evident by the age of 50 years, although it's not all that uncommon to see it between the ages of 55 and 60 years. At the time of diagnosis, the primary marker that we use to evaluate lung function, the forced expiratory volume in 1 second, or the FEV1, tends to be less than 50% of predicted values in normal adults. And unfortunately, at the time of diagnosis, the 5-year survival for patients with COPD tends to be less than 50%. Although the diagnosis of COPD has traditionally been made based on medical history as well as symptoms, spirometry, or pulmonary function testing, is actually considered the gold standard and is the most reproducible, standardized, and objective way of measuring airflow limitation. In patients with COPD, the hallmark of the disease is expiratory airflow limitation. That is, patients can breathe air in, but the gas trapping and hyperinflation that occurs secondary to airflow obstruction tends to be the problem. We measure 3 different components when conducting pulmonary function tests. The forced expiratory volume in 1 second, or the FEV1, a measure of the strength of the lungs, and the forced vital capacity, the FVC, a measure of the amount of air that can be blown out of the lungs, will all decrease. In addition, we use the ratio of those 2 parameters to help classify patients with COPD. As mentioned previously, patients with COPD tend to have elements of both emphysema as well as chronic bronchitis. The picture seen on the right shows a gentleman younger in age, more overweight, with more of a blue tint seen to his skin. This is rarely the scenario encountered in clinical practice due to the fact that patients with pure chronic bronchitis tend to have a very high incidence of right-sided heart failure, which contributes to a very high and early mortality rate. The picture seen on the left is more of the classic scenario encountered in clinical practice. It's an older gentleman, he has less weight on his body, he's leaning forward in that tripod position trying to take the pressure off of his diaphragm to help him breathe better, and he's using his accessory muscles in and around his ribs, as well as his trapezius to help him breathe better through those pursed lips. In addition, the lack of weight seen in the patient is due to an increase in catabolic factors encountered in patients with COPD. The airflow limitation encountered in COPD is due to a variety of different factors, some of which we've only just begun to learn about. In general, the chronic bronchitis and emphysema components are what we think contribute primarily to the symptoms encountered in patients with COPD. The disrupted alveolar attachments seen in the top right-hand corner of this diagram are secondary to emphysema, or the breakdown of lung tissue. In general, the lungs are able to pull air in, but they cannot push the air back out, leading to gas trapping and hyperinflation. In addition, goblet cells will start to hypersecrete mucus, secondary to chronic inflammation. and inflammatory cells will begin to obstruct the airflow throughout the lungs, contributing to the dyspnea and exercise intolerance seen in patients with COPD.